Dr. Ajeeth Samud, microbial spectrum of eyelid and orbital infections.
It is said that a picture speaks 1,000 words. Now, when we have a child who comes to the OPD with this kind of presentation, which complication is going to be our worst nightmare? And the very reason that we think of such a complication is the impetus for my research topic, microbiological spectrum of eyelid and orbital infections in patients treated at a tertiary hospital in South India. Good morning, I am Dr. Ajeeth Samuel, and it is my pleasure to be here with you. So my eyelid or orbital infections, if left untreated, can progress to severe complications like cavernous sinus thrombosis and many more. So ideally, these patients would require gram staining followed by culture sensitivity, and so that we have the most effective treatment. However, microbiological tests may not be readily available. So knowing the most common pathogen can help us start the right empirical treatment. My research objective was to identify the most common bacterial or fungal infection or the pathogen and evaluate current empirical antibiotic regimen and suggest updates. This is a descriptive cross-sectional study. All patients with eyelid or orbital infections who needed to undergo pus culture and sensitivity were included in the study over a 1-year period. All 189 patients underwent gram staining and followed by culture on 5% sheep blood agar and antibiotic susceptibility testing. We divided the patients into two categories based on age: below 18 years, which accounted for 19%, and above 18 years, which accounted for 81%. And there was an almost equal male to female distribution. Now, this slide tells us the most common infection below 18 years, which was preseptal cellulitis, and most common above 18 years, which was lacrimal sac abscess. Table 1, out of the 189 patients who went gram staining, 116 showed smear positivity. Table 2 shows 189 patients who underwent culture sensitivity, showed 157 showed growth. Table 3 is a comparison between the smear result and the culture result. So out of 116 who had smear positivity, 111 showed culture, and out of the 5 that did not show culture, 4 were gram positive and 1 was gram negative. And out of the 73 which were smear negative, 46 showed culture, which is a huge 63%. This is a broad categorization. The most common gram-positive isolate was Staphylococcus aureus, and the most common gram-negative isolate was Enterobacter species, which was a new finding in this study. Now let's break it down even further. Under 18, the most common gram-positive isolate was Staphylococcus aureus, and the gram-negative isolate was Haemophilus influenzae. And for above 18, it was coagulase negative Staphylococcus, and for gram-negative, it was Enterobacter species. Now, it is seen that chloramphenicol and cefuroxime was the most sensitive against all the gram-positive bacteria in both under 18, above 18 age group. Special note on fluoroquinolones, which showed round the house least sensitivity except in Streptococcus above 18. So in conclusion for this, we would like to change systemic cefotaxime to systemic cefuroxime. Now for gram-negative bacteria, it is seen that tobramycin, chloramphenicol, and polymyxin B were sensitive across the board. Again, fluoroquinolones were least sensitive against Enterobacter species, which we found out to be most in our particular study. So this enforces the current regimen which we follow, which is chloramphenicol, polymyxin B, and tobramycin for gram-negative organisms. Previous literature have been done similarly, but these concentrated on singular infections, and also in this study we have shown a drastic shift in fluoroquinolone sensitivity over the years. In conclusion, we found that we only had bacterial isolates from the 189 patients, the most common gram-positive being Staphylococcus aureus, followed by coagulase negative Staphylococcus, and the most common gram-negative was Enterobacter species. 63% of our smear-negative samples demonstrated growth, which underscores the importance of sending all patients for culture sensitivity despite your gram staining results. The most common, for gram-positive, the most susceptible was chloramphenicol, least sensitive was fluoroquinolones. For gram-negative, it was chloramphenicol with polymyxin B. And one particular change that we would like to propose is for gram-positive infections, parental cefotaxime to be replaced by cefuroxime. Thank you.
Thank you, Dr. Sab. You are very good study, good number, and I think good message also, because fluoroquinolones, they are going on the taking on the back seat, and old antibiotics, they are coming up. So I think we should take this message.
Yes,
I think it's very good study and good number also.
Thank you, sir.
You only studied on the bacterial part, not fungal part?
We did not have any fungal in these 189 samples, ma'am. So what we usually do is, even on gram staining, you are able to find out if it is a fungal specimen, and then we can go ahead with the KOH and so on, Sebrod's potatoes, agar for culture and growth. However, for these 89, we only found bacterial isolates,
Not a single case of fungus.
not one, which was also very, how do I say, enlightening for us. But yes, we did not find any fungal for out of these samples that we took.
Have you got any methicillin resistance typhorias?
Yes, we did receive some methicillin resistant, but it was also a small proportion. We had 25% of our Staphylococcus being methicillin resistant.
What medication used to work for that?
Vancomycin had to be given for those patients.
Okay,
Yes.
fine. That you should have mentioned actually. Huh?
Okay. Yes.
Regarding sir said, of course, you should always, I think, cut down the fluoroquinolones. It's sometimes like becoming like a over-the-counter medication these days.